Hi there, this is Rob Arntfield speaking to you. I'm an assistant professor at Western University in London, Canada, in the Division of Emergency Medicine and the Division of Critical Care Medicine. Also joining me and contributing on this screencast is Dr. Danny Peterson, a senior resident in our emergency medicine training program. This module is all about how to assess the left ventricle and its function at the point of care using point-of-care echocardiography. In particular, this initial episode focuses on the concept of the global assessment approach, the eyeball method, as well as the parasternal long axis view, how to obtain it and how to interpret it. The assessment of LV function in a patient in shock is of tremendous value, whether on the wards, in the ICU, the emergency department. It can help clarify quite a bit. Further, determining the LV function after an intervention, for instance, insertion of a balloon pump or the addition of some inotropes, may be of great value to the clinician at the bedside as well. Cardiologists have long been interested in quantifying and determining LV function. The fractional shortening approach, shown here with a measurement of the end diastolic diameter of the ventricle and an M-mode approach with the end systolic diameter, has been a favored method for decades. Over the past 10 or 15 years, however, the standard method of quantifying LV function has evolved to be the modified Simpson's rule. Now, this rule makes some geometric generalizations and some complex calculations combined with a series of views obtained 90 degrees to each other at the end of diastole, at the end of systole, and it spits out an ejection fraction number. This is a step forward compared to the fractional shortening method. However, there are a number of steps along the way where human error and inter-user variability may create vastly different results in terms of ejection fractions. All the same, it's probably still the best we have for a quantitative method. That being said, I think what we'll say next may not shock you, and that is that quantitative LV function in the ED or in the ICU is neither practical nor is it necessary. Instead, the eyeball method is preferable. That is, just looking at the ventricle, either in the parasternal long axis or the parasternal short axis, or ideally both, as well as other views if you have them, and determining if the ventricle is functioning well, really well, not well at all, or terribly. And this approach has been endorsed and studied by both intensivists and emergency physicians, and it's shown to be quite accurate. We favor a 4-category assessment of gross function. The LVs must be classified. Too few classifications of function result in overgeneralizations, and too many different classifications of function result in clinically insignificant distinctions between categories. So, as I alluded to, the layperson parlance of whether the ventricle is good, too good, bad, or real bad can easily be converted to the echocardiographic terminology of normal, hyperdynamic, depressed, or severely depressed.